Today we will look at the classification of psychiatric disorders, why we need to classify and what are the advantages, what is the utility. Now, one of the main reasons that we do a classification is to understand. So, we bring the information under headings that are similar and arrange it in a systemic rational way, so that it makes some sense, and we create something called a taxonomy, a scientific classification that certain syndromes, disorders, illnesses, conditions have similar symptoms, similar manifestations, and we group them together, while another condition may have other symptoms, other manifestations, other disturbances in behavior or pathophysiology, and we group that together. And we find that over time these seem to happen together, and that when we treat with certain ways of treatment, they respond, and we are able to predict the outcome and prognosis and so on. So, that is the basis of classification, and over time with experience we develop something called syndromes. So, those are symptoms that happen together that fit in a conceptually understandable way, and we call those syndromes that happen together, and we then find effective management strategies, treatments that seem to work, and over time we find that they are very effective, and then we may be able to do RCTs, randomized control trials, which can establish the evidence base for certain treatment protocols. So, that is how medicine develops, and that's how psychiatry is also developing. Unfortunately, psychiatry is not so advanced as in other parts of other branches of medicine, where they are able to diagnose, make classifications based on pathology or microscopic finding. We are still at the syndromal level. So, we classify according to syndromes. As a step forward, they have now established operational definitions. So, if we say certain diagnostic criteria have to be present, and some may not be present, and if these happen, 5 of 8 symptoms have to be present to diagnose particular condition. We find that also in rheumatic fever, major and minor criteria. So, in psychiatric disorders also they have operational definitions. Once we make a classification, once we have a diagnosis, we are able to share our knowledge with other colleagues, with other professionals, with the public health sector, public health research and so on. And we give a diagnosis that immediately gives a lot of information about that condition. We do not have to give a detailed description of the history, and once a condition is identified, that tells us about the cause, the prognosis, what are the treatment options and so on. So, there are a lot of information that can be shared with just say 1 or 2 words. The epidemiological basis of illness. So, we are able to use diagnostic categories, diagnosis to establish whether a person or in a population, what is the incidence, what is the prevalence of a particular diagnosis, and what is the occurrence in the year or the month or the gender basis, or research so many epidemiological factors, and that will give us some understanding about the etiology, about the spread, about the occurrence, and it will help us to create health information systems, so that for a region or for a country they are able to establish what are the types of disorders, what are the psychiatric conditions, what is the percentage of occurrence. This will help us to plan services, to make allocations for certain drugs, what type of facilities we need, and so on. So it's not possible to have a mental health service without a classification system, if you want to put it strongly. And finally, for research, we need clear operational definitions that establish a condition without much doubt, so that it's done with certain reliability, and then we are able to research the causative agents, etiology, treatment options, effectiveness, and so on. So many things can be done once the diagnosis is made reliably. Now, in the as psychiatry has evolved, two psychiatric diagnostic systems have been used. One is the international classification of diseases used by the World Health Organization, and that most of the world uses international classification of diseases, which is now in the 10th revision, and the 11th revision is now being prepared and should be out within a year. While the American system, they have something called the Diagnostic and Statistical Manual of Mental Disorders, and the DSM has gone through several editions. Now they are in the 5th. There is a tendency for both these to come together, and there is a lot of work trying to make the two systems similar, so that when you diagnose schizophrenia in ICD, it is the same as if you diagnose schizophrenia in the DSM, so that there is not much difference in the two. Now, looking more in detail at the ICD system, the psychiatric conditions or behavioral disorders are found in chapter 5, and they are grouped under a code called F. So, we have F1, F0, F1, F2, F3, and so on, and each one is a separate grouping. For example, F0 is all organic conditions, all conditions of physical or the pathology can be established, which manifest with behavioral disturbance, with psychological symptoms. F1 are due to psychoactive substances, drugs that are abused, substances that cause dependence, addiction, which can cause psychiatric disturbances like dexamphetamine, cannabis, even alcohol. Then we have F2 is the most important, is probably the most important problem in psychiatry. It takes up a lot of time and effort and resources, the schizophrenias and similar conditions. And we have the mood disorders, the affective psychosis as they are called, then the various neurotic, the earlier term, or stress related due to some external event causing behavioral disturbance, and the conditions of physical complaints without organic cause, somatoform disorders. Then there are behavioral patterns associated with physical disturbance and psychological problems. Disorders of personality is another big category with evolving criteria. Mental retardation or mental handicap or mental impairment, usually condition that we find from birth or in early childhood. Similarly, the psychological development problems, again starting in childhood. And a whole category of conditions that are found in childhood, which usually improve or they recover once they become adults. So, looking a little more into detail or trying to look at it in a more conceptually understandable way, the same chapter 5 or the F code, we have this whole big category called organic disorders, which are psychiatric problems due to obvious physical illnesses, which we will come to as a separate lecture, but maybe due to brain pathology or systemic illnesses that affect the brain function, so that you get a dysfunction of the brain. These can be both acute excuse me, can be both, organic conditions can be both acute and chronic. So, again we will go have lectures separately on all these different conditions, but it is mainly here we are looking at the time. So, acute is very acute onset, while chronic is a long term condition, which usually leads to gradual deterioration and death. So, prognosis is usually very poor. So, these are a whole lot of organic conditions which really should not be managed or treated by psychiatric services, mental health services, except to manage the behavioral manifestations. Sometimes we may have a role to play in managing some behavioral excitements, insomnia and so on. The real province of psychiatry is the functional conditions and other conditions which we will mention later. So, the functional mental illnesses comprise of two major categories: the psychosis, major mental illness, and minor mental illness or neurosis. The term neurosis is no longer used, it is an old term, but it denotes mild mental health disorders. So, in the major mental health disorders which cause a severe disruption in all aspects of mental functioning, behavior, cognition, emotion and so on, we have the schizophrenias, and then we have the mood disorders, affective psychosis, which mainly affect the mood, but you have also cognitive changes, behavioral changes and so on. Then the minor mental health disorders are conditions where the person's functioning is not so impaired. They may be able to continue, but it is not optimum, and there is considerable distress and it causes considerable difficulties to the person, and these are the common anxiety disorders, depression, somatoform disorders, OCD and post traumatic stress disorder. And then we have a whole other category which we will come to later. So, when we look at the major mental illness, we have organic disorder, as we have already mentioned, which have some characteristic symptoms which should alert a clinician that they are dealing with an underlying organic problem. It is very important to detect this very early, because treatment is very different and it can lead to different outcomes. If an organic condition is not recognized early and treated properly, it can end fatally. It is very important to find out what is the underlying issue here and treat. So, the fundamental sign of organic psychosis, particularly acute organic psychosis, is clouding of consciousness, and this is manifested by disorientation for time, place and person. So, very simple, very easy, very straightforward first step in any psychiatric problem is to establish whether there is clouding of consciousness. Second important characteristic symptom in organic psychiatric problems or organic psychosis is memory disturbances. So, this can be retrograde, anterograde, particularly the recent short term memory disturbances. Then we may have a history of physical pathology or a past history, a diagnosis card or attending clinic saying that the person has a heart condition or a liver problem, cirrhosis, or he is known hypertensive with possible cerebral arteriosclerosis. So there is a known physical pathology. And when we actually do a physical examination and laboratory investigations, there is invariably something positive. So you may find a high fever or a tachycardia, icterus, flapping tremor, upgoing planta, rigidity, and so on. And the investigations, there may be high ESR, blood count may be abnormal, there may be abnormal biochemical changes, the serum bilirubin might be high or the urea levels may be high. So, we will find something abnormal, or the X-rays or the brain imaging or CT scans, MRI will return something that shows that there is an organic cause. And the main line of management, as I mentioned earlier, is to treat the underlying organic condition. It may need added psychiatric management if there are behavioral disturbances that need to be controlled, but the main line of treatment is to find the cause and treat. Now, in functional disorders, on the other hand, there is clear consciousness. Person is well oriented to time, place and person. There may be some exceptions, particularly acute schizophrenia, but as a rule they should be conscious. And their memory should be normal. There should not be any memory disturbance. Again, there are exceptions. You may get disturbance due to psychological factors, but they are temporary. The memory is actually there, but they may not be able to retrieve it in a stressful situation. Organic pathology usually is not there, not to the level that will cause the symptoms that we are seeing, particularly brain disease. So, usually they may have some other minor physical disorder, if at all, but that does not explain the manifestations that we are seeing, the behavioral disturbance we are seeing. And all the laboratory investigations, the physical examinations, everything comes out normal. And here the treatment is for the psychiatric conditions, obviously, with medication or psychological forms of treatment. Now, looking at the organic disorders itself, as we mentioned, they can be divided into acute and chronic. So, in the acute conditions, it is characterized by sudden onset. So, there is a short duration, within a few days, a week at the most, the condition manifests itself, and characteristic finding is alteration in the level of consciousness. And very important is that if you can find the cause and treat adequately, prognosis is very good. The patient will make a full recovery. And the example of an acute organic disorder is delirium, which you would have seen in with high fevers, septicemia, or alcohol withdrawal, delirium tremens, or after epileptic seizure also sometimes you see this kind of change in the level of consciousness which lasts for minutes to few hours. Then the chronic organic disorders, the onset is again very gradual, insidious onset, slow progression, usually slow deterioration. Patient is generally conscious, so they may be able to tell you the place, time, person and so on reasonably, but characteristically there are memory disturbance, particularly short term memory is lost, and that is usually the presenting complaint and finding. These conditions are gradually deteriorating, and the prognosis usually is poor. There is irreversible changes and usually death, they say within 2 to 5 years. And prototype is dementia, which we get in old age. Now, looking at the functional disorders, so this is actually the whole field of psychiatry, the major mental health disorders, psychosis, and they are generally not understandable psychologically. We are not able to understand why this person has developed this illness at this particular time, with his background. Seems to be something that comes out of the blue or comes out endogenously, some kind of genetic neurotransmitter imbalances and so on, not explainable by the environmental factors to some. So, we call it endogenous, something coming from inside, and usually the first episode needs admission, at least for assessment to initiate treatment and see what is effective. But there are approaches or schools of management that do home care. So, they are able to visit the person at home and care for the person at home, and usually they need medication and they respond to medication because they are mainly endogenous imbalances in various neurotransmitter systems, and they effective treatments are available, and it is not ethically correct to delay or withhold treatment, make the actually psychosis worse. Unfortunately, most people who develop major mental health disorders do not have insight, they do not realize they are mentally ill. So, sometimes it is the relations or other services that have to initiate and sometimes compel treatment. So, the person gets better, as they recover the insight may return. So, this problem of insight is makes management difficult. Some of these conditions, particularly like schizophrenia, may need long term rehabilitation, support, maintenance treatment and so on. And the examples are the mood disorders like depression and schizophrenia. Then the other functional disorder is minor mental health disorders. So, here we say that the impairment may not be so severe that it affects all aspects of brain function or mental functioning, but there is impairment and distress to the person. When we look at the illness or the manifestation symptoms, we can understand some of the symptoms looking at the person's background, his personality, the situations, the events that he has undergone. There may be a current stress, there may have been an event in his life that caused him some distress, and the symptoms can be understood as arising from some external event. So, we sometimes call it exogenous type of conditions, because there are some like anxiety neurosis, where the anxiety may be persisting for a long time. It seems to be a part of his personality. So, it may not be explainable by some external event, but usually we can do that. They may not need admission, and most usually they do not want admission, can be managed from the clinic or from outside practice. And in contrast to using medications in major mental health disorders, here the first line of treatment, preferred treatment may be psychological, various forms of psychotherapy, cognitive behavior therapy and so on, and physical methods like relaxation can be quite effective. Usually they retain good insight. In fact, the insight may be a little hyper, they may be a little more concerned and worried about their condition, whether they have a mental illness, and seeking help So, the insight is a help in the treatment because the patient is very keen to get better. Very often when they are, it's due to some exogenous event, stress or some trauma, we are able to help the person recover either by removing the stress or improving his coping skills and strategies so that he can face what has happened. But they may again get a relapse if they are faced with another stress, so they may need long term support. So, some of the examples, as I already mentioned, anxiety, various forms of depressive illness due to, say for example, the loss of a loved one and somatization disorders. Right. Then we come to the other conditions that we mentioned, miscellaneous, which do not fall clearly into this kind of classification system that we were trying to explain, which is really just an aid to help you conceptualize, put things in different pigeonholes, so that we understand overall. But there is a lot of overlap, and so it's not a very perfect system, as I will explain later. So, the other conditions do not fall into this different categorization. One is the sexual problems, sexual orientation and sexual disorder, sexual function and so on. Problems that occur in children and adolescents, which seem to have some characteristics of their own, like ADHD, attention deficit hyperactivity disorder, neurosis and so on. Personality disorders, another large area. We are still improving our understanding, where management options are limited and seems to affect the person for his life. It's a characteristic behavior pattern, response pattern. Various eating disorders may be more important in Western countries or more commonly seen there, anorexia and bulimia. Sleep disorder, another condition that is becoming more and more noticed, particularly various types of insomnias, but some people have hypersomnias and some have a tendency to fall asleep suddenly. So, these are different types of sleep conditions. And finally, mental retardation or mental handicap or impairment, which is not a psychiatric disorder, but there is impairment of intelligence, usually due to some birth injury or some genetic factor. Person's intelligence may not be normal. Right. So, now I would like to present to you another view. So far we have been looking at psychiatric conditions as categories, as distinct syndromes that fit certain patterns and that can be grouped clearly, distinctly and so on. But unfortunately, the clinical picture has not been so clear, and there has been a lot of overlap and exceptions and so on. So, with a lot of research, with modern research, particularly what we call genome-wide association studies, GWAS. So, these are very large population level studies looking at the genetics and what are the conditions, finding the associations between the two and so on. And they find that there is a lot of overlap, and particularly the two major categories that Kraepelin described. He divided psychiatric disorders into psychosis, the psychotic disorders, into schizophrenias and the mood disorders. But we find that when we really go into their background and look at the family history and so on, there is a lot of overlap, and they do not seem to breed as pure as we originally thought. And looking at the symptoms profile and the clinical picture over time, there is considerable overlap in the two conditions. So, they have now worked out other ways of trying to understand, rather than trying to look at it in as distinct categories, but we call a spectrum. So, it is a kind of gradient from one extreme to the other extreme, and when certain factors are more prevalent we get something that are much more characteristically neurodevelopmental. We can clearly see a neurological basis. And some, as we get go to the other end of the extreme, we get what we call affective pathology, so mood disturbance and so on. So, we get a kind of gradient from one end to the other end, and the different conditions may fall. So, mental retardation, autism and so on are clearly neurodevelopmental. We can see the neurological basis, while conditions like schizophrenia do have quite clear brain pathology changes that can be shown by the new imaging techniques and so on and post-mortem. And then as we go on, conditions that are more manifested by mood changes, depression, anxiety and so on, which do not clearly show a neurological basis. So, trying to understand this occurrence, they have tried to develop a conceptual model, which I will try to explain. This is found in a article that came out recently, and I will give you the reference so you can read it yourself to understand. It is a little complicated, so I will also try to explain it in a simple way, but it may be worth reading the article itself. So, at the genetic level, there may be considerable variation, and different types of structural, the DNA structure may contribute to changes at a higher level, which then finally manifest as various psychiatric disorders or the clinical syndromes that we have. So, starting with the gene variants. So, one single gene variant may influence several biological systems. So, one gene may impact on several, or one gene variant may impact on one system. So, these are the various genetic variations, changes in the genetic structure, maybe single gene or multiple genes, as you see, and the different biological systems. By biological systems, we mean usually some of the neurotransmitter neurons that are linked together by some of the neurotransmitter chemicals, for example, the GABA system or the acetylcholine, dopamine, which may be linked to schizophrenia. So, there is some genetic variation can cause disturbances in some of these neurotransmitter systems, which may involve different parts of the brain. The neuronal pathways may be linked from the striatum to the cortex or to the basal ganglia or to the limbic lobe, and that may then cause changes in various functionings of the brain that we understand in a more complete way. For example, memory disturbances, where there may be changes in the acetylcholine system, and that may be influenced by some genetic variation. So, memory or movement, which may be influenced by dopamine, pleasure and so on. So, these are neural modules, and they may be due to some kind of abnormalities or linkages between different parts of the brain, and these manifest due to environmental influences like traumatic event or some stress that could impact on the various modules, and as stochastic variation, that is changes in the genetic in the genes, in the DNA structure due to random changes. And the manifestation can be in different domains that have been identified. So, for example, the cognitive impairment in memory, in concentration, in attention, negative symptoms, withdrawal, lack of motivation, positive symptoms like delusions, hallucinations and so on, and mood changes, depression, elation. So, these are different domains which are impacted by changes low down, and a various combination of domain dysfunction can result in all the psychiatric disorders that we know, from mental retardation to affective disorders. So, this is the type of genotype and this is the phenotype. So, how do we get from here to there, and this is a conceptual model trying to explain this. So, it is just a conceptual model, and this is what current researchers are working on. Another way of trying to understand this kind of spectrum, in contrast to the categorical model that we described earlier, which is the basis of ICD and DSM, is to look at different ways that the brain functions, or different functions of the brain, and one may be cognitive processing. So, that is to do with attention and memory and so on, mood, feelings of depression or elation or fear, volition, the drive to do something, the willpower, and the feeling of anxiety. So, these have been identified as possible functionings in a normal brain, and they when they become extreme or disturbed, they may result in various conditions that we diagnose. So, different combinations of changes in cognitive processing and mood can result in a psychosis, which may manifest as a bipolar psychosis or as a schizophrenia, depending on the particular type of symptom pattern. And similarly, you can get a depression if the mood component is very strong, and with some cognitive impairments in concentration, attention and so on, you may get a depressed person. In anxiety, the anxiety symptoms may be very prominent, the fear, the avoidance and so on. So, these different conditions may manifest due to different combinations of impaired brain function. So, these are just ways of trying to explain the wide variation that we find, and it is considered a spectrum model rather than a categorical model. Thank you.